Okay, so we are live right now. Good evening, Dr. Jaishree Sharad. Today I have a very, very special guest. My guest is the internationally renowned and best celebrity cosmetic dermatologist, Dr. Jaishree Sharad. She is also the international mentor at the American Society of Dermatologic Surgery and the board of directors at the International Society of Dermatologic Surgery also. She is also the director at Skinfiniti Aesthetic Skin and Laser Clinic in Mumbai in India. And I guess I can do this the whole day because regardless how much I speak about your tremendous experience and young jury, it's not going to be fair enough, Dr. Jaishree. First, thank you so much for accepting to join me in this webinar and for giving me some of your quality time.
Thank you.
Thank you. So today we are going to talk about the lips and the eyes. And you agree with me that those are tools of expression, showing love, showing sad, showing anger. Before we talk about how to beautify those areas, could you tell us more about the aging process of the eyes and the lips?
Yes. First of all, thank you, Dr. Noury, for inviting me. It's such an honor. And I'm so happy to be speaking to all of you, whoever's watching in Egypt and in India. Thank you for being here. So the eyes and the lips actually are the most attractive parts of our face. They are, they say that the eyes speak, right? And when your eyes are hollow, when you have sunken eyes, you may have slept for 10 hours, 12 hours, and you still feel tired. You still look tired. You don't feel, but you look tired. And people will tell you, oh my God, you're not looking fresh. And when the lips are thinner, it sort of gives you a very mean look, if I may say so. Now, why does this happen? Now, when we're talking of aging, we know that aging is not just a process that happens in the skin. It is something that happens all the layers. So when you talk of the tear trough area, I'm just going to show you. So what is the tear trough? If you drop a line from the medial limbus, drop a perpendicular line. So from the medial canthus to that line, okay, in this area here is the tear trough. And lateral to the tear trough is the entire infraorbital hollow. Now, in the tear trough area, we have the bone, okay, and we have the muscle and we have the skin. That's all that is there. But beyond that, in the entire infraorbital hollow, we have 7 layers. So we have the skin. Below the skin, you have the superficial fat pads. Then you have the muscle. Then you have the soothe. Then you have the lamina. And below the deep lamina, you have fat again. And then you have the periosteum. With age, okay, what happens? The entire bone starts to resorb. And a lot of Indians, Dr. Noury, I have to tell you that, our maxilla is anyway a little concave. So we have, even at a younger age, we do have a very prominent infraorbital hollow. Now, that's one part of it. But with age, what happens is, the superorbital and the the superomedial and the intralateral part of the orbital rim starts to resorb first. Okay, so you first, and then the bone starts to resorb, then the deep fat starts to get, again degraded. The muscle becomes thin. The ligament, you have the tear trough ligament, which goes as the orbitomalar ligament, and then you have the zygomatocomalar ligament here. The ligaments tend to attenuate. Okay, so they're no longer able to support. And then the muscle is thin. So what happens? The basic foundation is going down. It's lost. So imagine this, there's no foundation to the entire house. So the house is going to crumble. So what happens? The superficial fat layer and the skin anyway, again, because of collagen degradation, is becoming thinner. It's losing its elasticity also. So the superficial fat and the skin tend to sag, which is why you have the infraorbital hollow. That is something that progressively happens with age. It also happens in people who age faster due to a bad lifestyle. Sleeping late, smoking, eating, unhealthy eating habits, Sometimes it's also shown that pollution can cause a lot of free radical damage, stress. So all these factors will add to the aging process. And you also see the degradation of the fat in such cases. So that's what happens in the eye area. Okay. And in the lip area, what happens? So in the lip, of course, when you look at a youthful lip, it is fuller, right? Just as when you look at the tear trough, the under eye area, it's fuller and there is no transition between the lid cheek junction. It's a smooth curve, right? But as we age, you see that lid cheek junction, you see the transition. Similarly, in the lip area, the lip is much more fuller. With age, what happens is, again, there's a bony resorption. So your maxilla is getting resorbed, your mandible is getting resorbed. The dental arcade starts to go behind. Okay, the lip elevators, they tend to get loose. And so, that's the reason why we do myomodulation now. And with all that, the upper lip tends to curve inwards. So it looks thinner and it starts to roll inwards. And that's exactly what happens. And because of loss of volume in this area, in the chin area, okay, the lower lip starts to go inwards. So it's not sort of, really full as in a younger patient. So this is basically the whole concept of aging. Now, yes, you were asking me something?
Just continue. No, I didn't interrupt you.
So when we actually look at the lips, at a youthful lip, what is a youthful lip? Now, this is the upper part of the lip. This is the cutaneous part, and this is the lip part, the mucosal part of the lip. So in the upper area, the upper lip, you have, these two nice filtral columns from the base of the nose, from the columella to the tip of the Cupid's, peak. So you have two filtral columns and you have a filtral hollow. And then you have this really nice upper lip, which is a bow-shaped lip, and which has this, this particular area is called the Cupid's bow, with two peaks here. They are the Cupid's peaks, right? Now there are three tubercles in the upper lip. You have the median tubercle, and then you have two lateral tubercles. You have a nice white roll, which is the vermilion border, and then you have the vermilion. When you look at the lip, the lower lip, it's again two tubercles are there as opposed to three, but again there is a nice full body and there is a white roll, right? And then you see the commissures, the oral commissures. You don't have marionette lines in a younger person, and the lip is sort of curved upwards. It's not drooping down. The DAO here, as we age, starts to get more prominent because your elevators are becoming weaker. So, but in a youthful lip, you do not see the DAOs. You do not see the downturned smile. In older people, you see the downturned smile. Then, when you look at the proportion between the upper and the lower, now Caucasians like a 1:1.6. They like the phi ratio, where the lower is a little bigger than the upper. Africans like 1:1. We also, Indians, like 1:1. Asians like, a bigger upper and a smaller lower. So the ethnic variations are really lovely. I want to know what the Egyptians like. Doc, what about the Egyptians?
We are like you. By the way, most of our patients do also have the same problem of the periorbital area and the perioral area.
Yeah. So that, and then what happens is, if you drop a line, in the profile view, if you drop a line from the subnasion to the pogonion, what happens is, from here to here, if you drop a line, the upper lip projects 3.3 millimeters ahead of that line, and the lower lip projects 2.2 millimeters. So which means the upper lip should be slightly projecting upwards ahead of the lower lip for a nice youthful lip. So these are all the characteristics. And then you look, the lip has to have a nice harmony, which means, you should look at there should be no perioral lines, there should be no marionette line, there should be no mental crease, all these things. And when you're assessing the lip, you also look at the person in animation. So ask the patient to smile. So when the person smiles, you look whether there's a gummy smile, You look at how the dental arcade is. Sometimes people have an anterior inclination. So if the teeth are already projecting outwards, you don't want to put too much filler out there in the upper lip, then it would look odd. So all these things are really important in a youthful lip vis-a-vis, when we're trying to recreate it in the older lip. So that much about the aging.
Okay, this is pretty amazing. Dr. Josh, I guess one of the advantages of being a dermatologist is that you are very familiar with the skin. And I guess you agree with me that regardless the type of filler that you are using, how much is it a perfect filler or not, it won't do any good in a bad quality skin. What are your own tips and tricks on beautifying or enhancing the skin before you place your products in order to give a better results?
So that's a very nice question. See, what happens is, again, I'm going to talk to you about Indians. We very commonly have periorbital hyperpigmentation, right? So, and, it could be due to low hemoglobin. It could be because, we are atopics. And if you're constantly rubbing the eye, there's friction, which is causing the periorbital hyperpigmentation. Anyway, skin types 3, 4 will, end up with more PIH. So, if we're allergic to any eye cosmetics or any sort of foundation, we develop, an allergy and an allergic contact dermatitis or a PIH later. So all these things, acanthosis, nigricans, okay, that's again very, very common in us. So all these will lead to a darkening under the eye. And if you don't treat that and you only treat the sunken eye, agreed, when you treat the sunken eye, when light falls on it, it reflects. It doesn't cast a shadow. So a part of the dark circle does look much better. But if there's hyperpigmentation, the patient will not appreciate the filler. So it's very important to treat the skin, as you rightly said, to treat that hyperpigmentation. So what we do is, what I do in my practice is, of course, this area is really, it tends to get dehydrated very easily. It's a thin skin here. So I always ask them, I give them a nice moisturizer. I ask them to use a sunblock. I get their hormonal profile done. If there's hypothyroidism or PCOS, that needs to be corrected. I get their hemoglobin tested. That needs to be corrected if they have anemia. And then if there is any kind of atopy, then, you'll hydrate more, also give some vitamins, vitamin C, omega-3, vitamin E, to hydrate internally. And then we also give topicals. So a combination of, some skin lightener. It could be vitamin C, licorice, arbutin, kojic acid. So these kind of skin lighteners are given under the eye. And then sometimes very commonly also see blood vessel engorgement, right? So then in those cases, we also give vitamin K. So that's another thing. Now, when we give this for a couple of, maybe for 2-3 months or so, and then we also do combination of a 20% glycolic acid peel with, we alternate it with a Q-switch Nd:YAG laser. All right. So to treat the hyperpigmentation. So all this depends on the degree of hyperpigmentation. So if it is subtle, it goes off with the creams. If it's a little more, then you have to add the peels. And if it's really bad, then you have to add the laser, the Q-switch Nd:YAG laser. I don't have the Pico laser, but some of my friends who are doing the Pico are also very happy. So once you improve
Doctor, sorry to interrupt you, but when do you decide also to combine the energy-based devices on your treatment plan?
So once you have treated, so this is what we do in the hyperpigmentation cases when you have patients with periorbital hyperpigmentation. But if the patient also has laxity in the skin, that's what I was just going to come to, is that if there are lots of fine lines and if there is a little laxity, then I would want to do an energy-based device. So I would actually go and do a little bit of radio frequency, or I also would do a little bit of, high intensity focused ultrasound to tighten the skin there. If there is a laxity in the skin or if there are lots of those fine lines. I also like to do the microneedling with a derma pen. That I find with the PRP, it gives an amazing result in the skin texture. So you can treat, so there are three things that happen under the eye. You have hyperpigmentation, which you treat with skin lighteners, peels, and laser, Q-switch and DIAG. Then there is laxity of the skin with fine lines, which you can treat with an energy-based device, or with a microneedling with PRP. And then, of course, you have the tear trough and the infraorbital hollow, which you treat with fillers. Some of my friends do treat with autologous fat grafts. I have also started doing it. And finally, in really bad cases of orbital prolapse, or, if there are lots of, very bad festoons, you have to send them to a plastic surgeon for surgery, for a blepharoplasty.
Okay, since you came up with this autologous fat transfer, it's my first time to hear about it. I saw your post when you were doing a webinar about it, but what are the results? How much does it give you a benefit in this area?
So I have to admit that I haven't done many cases. I mean, just before the lockdown, which was in March, I think somewhere in the first week of March, I had Dr. Mario Goasis come from Milan, from Italy. And he was there at my clinic, and he conducted a workshop. And then I did only about 2 cases. And then the lockdown happened. So I have to be very honest. I do not have so much experience, but those 2 patients are really happy. And in one session itself, they're very happy. And the 2 other patients who came in as volunteers, upon whom Dr. Mario injected, they are also very happy. But March to now is hardly 4.5, 5 months. So it's very early to actually comment too much. But it's a cheaper option and a longer lasting option. One has to be very careful. I would still be, if somebody gave me to choose, I would still choose my hyaluronic acid fillers, because hyaluronic acid fillers are very, very forgiving. God forbid something goes wrong, you have the good old hyaluronidase to take care, right? What will you do if something goes wrong, if we have a vascular complication when we're injecting fat? And that really, is the fear. And maybe that fear will go when I do more and more sessions. But I think, with a hyaluronic acid, 2 things happen. You get a nice, you can treat the infraorbital hollow, but you also get a nice hydrating effect. The skin texture improves, So that I'm not too sure with the fat. I think you need to really, know the skill. And I don't know how much of a hydration and the glow it's going to give. And secondly, I have seen in the past, not from Dr. Mario's cases or not my patients, but I have seen in the past patients who've come to me with lumps under the eye after the autologous fat graft. Now, when I asked Dr. Mario about it, he said that, probably the fat was not fine enough. It was not the actual, in the way you have to centrifuge or you have to decant and you have to get those finer particles. If that is not done properly, you may get lumps, is what he said. So all in all, it's a learning curve, but as of today, I would still say hyaluronic acid fillers.
I see. So what are the rheological properties that you should be looked upon when choosing the filler product for the tear trough area?
Yeah. Oh, that's so important. So we have to understand that hyaluronic acid is hydrophilic, which means it is going to attract water and it is going to swell up, right? So we cannot use a product which is going to be very, very hydrophilic. We cannot use a product which is going to be stiff. So a product with a high G prime is a complete no in this area. Okay. You have to use a softer filler with a low G prime. Okay. And something which is not as hydrophilic. So in my opinion, a softer filler, I love the Bell. Can I take names, Doc? Can I take names of the fillers? Is it allowed?
Yes, sure. By the way, my next question was that I'm going to tell you rate from 1 to 10 the certain filler product concerning if we're going to use it in the eye. So it's okay. You can use Nate.
So yes, so basically under the eye, as I said, a low G prime, softer filler, which is not so hydrophilic. So the Bellatero Balance, I like it. It's a polydensified, technology, and it's a monophasic filler. I really like it. It's softer. I'm sorry, it's a biphasic softer filler. And the other one, which is really nice, is the Volbella. Okay, Volbella, it has a gel hardness of 15 milligram per mil, but it's not as hydrophilic. So these are the two which I really love under the tear trough. And every other filler that I have tried, I mean, I haven't tried the high G primes, of course, but I have tried the Juvederm Ultra and I have tried the Restylane. I'm not very comfortable doing them. With the Ultra, I see that it's extremely hydrophilic. It absorbs a lot of water. Sometimes it causes a lot of puffiness. In females who anyway have, during menstrual cycles, when they have puffiness, they tend to retain more water and the eyes really swell up. And if somebody has had, a lot of alcohol, then the next day again, the eyes tend to swell up. So they'll come to you and say, Doc, what's wrong? So it's always important to choose, the right kind of filler for the tear trough area. So never use a high G prime.
Okay. Do you have Dioxane in India or Perfecta?
No, unfortunately, we only have 3 fillers. We have the Juvederm range, we have the Bellatero range, and we have the Restylane range.
Okay.
What about you? What about you? I mean, what is your?
I'm totally agree with Bellatero Balance. It's totally perfect. I like the way how much is very smooth to be injected at your trough, and I think it's very forgiving because you see there's always this problem of having a puffiness under the eye with other types of fillers. So Bellatero is my number one, actually.
Yeah, mine too. Mine too.
Yeah. Doctor, concerning the injection technique under the eye, do you prefer to go medially and do like a fanning like this, or to come from laterally, or you prefer to use the insulin syringe at a 3-point technique? What is your preferred technique?
So, in April, the beginning of April, in the Dermatologic Therapy, my paper got published. I do various techniques, but my latest technique is injecting with a needle, 30 gauge needle. So I start with the lateral. So first of all, it's a young versus an old phase, right? So if it's a young person with a tear trough who does not need any mid phase, then you can directly go and inject the tear trough, right? But if it's an older person, where you see that the mid phase is also lost and the person needs a mid phase, it's always better to first inject the mid phase. So there was a very interesting paper by Rorich and Pessa where in a cadaver, they injected saline in the deep medial cheek fat pad. And they found that just by injecting this deep medial cheek fat pad, there was effacement of the tear trough, right? So that itself was a great...
It is like you are applying the concept of indirect beautification, like some people do when they start with the temple and the cheek, then they found that the whole tear trough defect has just disappeared.
It just disappears. So if it's an older patient who needs a tear trough and a temple, it's a good idea to inject these two first. And then what happens is your requirement for the tear trough reduces, right? So that's my usual technique in an older patient who needs these things. And then coming to the tear trough. So what do? I start with the lateral first. Often I see that when I inject, and as I told you, studies have shown that it's the inferolateral which goes first, right? When it comes to the bone. So this part tends to get hollow first. So if you inject the lateral canthus, the lateral part of the tear trough, a lot of times this gets lifted. It improves a lot. So I like to start with my lateral points. So my 3 points of injection, I will show you. So I would palpate my intraorbital rim. From the lateral canthus, I will just drop a line, and just below the intraorbital rim will be my first point of injection. All right. And this will be a perpendicular injection using a 30 gauge needle. And I use Gerhard Sattler's vertical supraperiosteal depot technique. What does that mean? That means with one hand, I pinch the skin, and with the other, I put my needle on the bone, and I deposit my product on the bone while I'm pinching my skin, right? The product goes on the bone. I don't inject more than 0.1 to 0.2 mil. And then of course, I always aspirate, although a lot of my friends do not, saying that when you inject on the bone, you don't need to aspirate. But, there's no harm in aspirating, because if you see blood, I have seen blood once, it's always better to be safe, right? So aspirate, and then, put a bolus right there. Now, when you're pinching and putting a bolus, and then you sort of withdraw your needle out, what happens is there is no backflow. Otherwise, there could be a backflow, and the product could come to this, a little bit of the product could come to the surface of the skin. And there are papers which have talked about it. So pinching with the other hand helps. Once I finish the lateral, then I drop a line from the mid-pupillary, the mid-pupillary line, okay? And then again palpate my inferior orbital rim. And just below the inferior orbital rim, lateral to that mid-pupillary line, is my second injection. And it is the same needle bolus technique, the vertical supraperiosteal technique, where you're pinching and going on the bone and you're injecting. Now, you have to remember that, where is the intraorbital foramen, right? Where is it? If you drop a line from the medial limbus and you go down about 7 to 11 millimeters, anywhere 7 to 11 millimeters in that line of the medial limbus, you can actually palpate the intraorbital foramen, because maybe not in a chubbier patient, but most of the time, you can feel your pulsations there. So that is a complete no-go zone. And Sebastian Cotofona has also said that sometimes it could also be in that mid-pupillary line, the intraorbital foramen, right? So you have to be careful, and which is why my second point of injection is close to the intraorbital rim, because if you're that close, you can't be there near the foramen. And secondly, I just do a little, just lateral to that line. So I'm very safe.
Yeah, and I guess you can always deposit a little bit of product lateral to this line, and you can just mold it medially. Or you don't prefer to use
I lost you.
Okay, can you hear me well right now? Dr. Jaishree, can you hear me?
Yes, I lost you. So,
okay.
So you were saying something.
I was saying, can you deposit a little bit of your product lateral to the line, and then if you do have a little bit of defect medially, you can mold it. You can mold it with your finger. Yeah,
correct.
Exactly. Okay.
Absolutely. So once you do that, you can just very gently mold it. Sometimes I like to take a cotton bud and just mold it, move it medially. My third injection point. So what I do is, this is my tear trough, okay? You can see the tear trough ligament. And, you can see that it goes down as the zygomaticomalar ligament. So I drop a line like that, and then I drop a line from the lateral canthus. That's exactly where the Redka Galadari point is. It's about, if you drop a line from the lateral canthus down 2 centimeters, it's a very safe plane, a very safe avascular zone. So I puncture with a 23 gauge or a 22 gauge needle, and then I use a 22 gauge cannula, and I go right up to my tear trough. And in this tear trough area, I will give micro aliquots, little micro aliquots of filler in this area, in the tear trough area. And I'm on bone, I'm below the muscle. So I scrape my cannula all along the muscle and go there. And then you can actually, because there's not much, many layers there, you can see the cannula also. But you should be able to see, you should not be able to see the tip of the cannula, but you should be able to see that entire, you know what I mean? You shouldn't be seeing a whitish thing, but you can see the cannula. And you deposit your product below the muscle. And it has to be, I don't do more than 0.05.
Do
I
you
have to
think
be
that
very
this
careful.
technique also provide you an advantage of doing a myomodulation since you are
Yes,
placing your product deep to the muscle?
absolutely. I think it serves the purpose of myomodulation. It serves the purpose of not over injecting. It's also very safe because with a cannula you are safer, and you do not end up with a tingle effect. So there are 4 benefits that I've already listed out here, and it's a beautiful technique. So that's my way of injecting. Now a lot of my friends do, I had done another paper back in 2011 where what I was doing is I was dropping this one from the mid pupillary line. I was going down, and lateral to it I was injecting, putting my cannula and doing the entire tear trough. Okay. So that's another way of doing it, going beneath the bone if you want to myomodulate. But somehow I like this technique of 2 needles and one. I just find that with one syringe, you can achieve what some of my colleagues who are teaching some things are doing with 2 syringes.
Yes,
So,
I guess that this is being smart is to use the minimal amount of product and to provide a very satisfactory results. Because
yes.
money wise,
Also,
sometimes patient can't afford to buy it to cover up for the price of 2 syringes.
yes, absolutely. I mean, and then if you save up on that one syringe, you can probably use that one more syringe for the lip or some other area on the face. So it's always advantageous to
Yeah,
try
exactly.
and, minimize and give them results with whatever best you can. I mean, unless, of course, the patient really has a lot of loss of volume and you need more syringes, you can't help it. But otherwise, I think you can do it with one syringe if you want to do the tear trough.
Perfect. So speaking about the lips, is it okay to use a filler, which is a high amount of hyaluronic acid in the lips, or what are also the properties of fillers you should be looking upon when you to do a filler injection in the lips?
So I do not like to inject any high G prime because it would make the lips look very stiff. I do know of some people who do voluma in the lips, but I don't know. I cannot do it. It would create a very artificial lip. It's always, see, the lips have to be soft and they should look full, but they should be soft. And you should be able to move your lips when you're speaking, right? So if you just put some high G prime filler there, it's going to look very stiff. And you will not achieve the myomodulation with a high G prime filler. So here again, you can use an intermediate G prime or a lower G prime, depending on how much volume you want to give to the lips. Now, are you trying to cause a lip flip because it's an older patient where the lips are rolling in, or are you doing a lip flip because the patient likes it and it's the trend nowadays, the Russian lips where you're doing the flip?
Yeah, we
Or
were going
are
to
you
talk
just
about this Russian lip technique. Yeah.
or are you just trying to do a nice volumization? Or are you doing the lip borders because the patient doesn't have lip borders or doesn't have a nice cupid's bow? So you have to decide, depending on all these, you have to choose the filler. So if I have to do the lip border, I will use a softer filler. I will use, again, a Belotero Balance or probably an intermediate. Or I would use, I used to like the Juvederm Ultra Plus. I don't know if do you have Ultra Plus or do you have 1, 2?
Yeah, but I'm not very fond of Juvederm.
Yeah.
I'm using
So I'll
Perfecta,
say,
and
okay.
I like also Teoxane in the lips. Mm.
So I'll tell you what, I used to like the Juvederm Ultra Plus till I realized that in a lot of
Mhm.
my patients, after a couple of months, the upper lip filler was migrating here. Have you seen that with the Juvederm?
Yeah, and actually it doesn't last that much. I always
Yes.
end up having, I don't know, this shelf, like this white roll border ends up
Correct.
having a shelf or like a
Yes.
ledge. Yeah.
Yes. Yeah. I agree with you. Which is why, we don't have the Teoxane or the Perfector. So I do the Belotero, or I like the Restylane Kiss in the lip.
Hmm.
You know, it somehow, it's a little difficult to inject. As so for beginners, the Belotero is better because it's a softer and easy to inject filler. But the Restylane Kiss is really, a nice filler for the lips. So
Hmm.
that's my
Doctor,
choice
do you
now when I
recommend
want.
injecting yeah, do you recommend injecting at the vermilion border itself or underneath it, giving the fact that the filler may spread?
Uh, I do not like to do the vermilion border, and
Mm.
so I actually, so if even if I want to flip it, I would do, so if I want to create volume, then I inject the wet dry border as well as the dry lip. But if I want
Hmm.
to flip, I will go just below the vermilion border, you know.
Hmm.
And you
Yeah.
can, if you just go below the vermilion border, you can also flip it. I also do a little, tiny struts here in the corner, in this area, in the
Mhm.
lateral part. I would do little linear struts, like how you do the Russian lips from, above. I would just do that to flip if in an older patient, if I want to flip it a little, I would do that in this area. But otherwise, I like to inject the body of the lip. That's
Mhm.
my personal choice. And a lot of times, I don't know if you know of Dr. Harris from London. Have
Yeah,
you
I
heard
know
of
him.
him?
He's like the father of my modulation. And he is the
Yes.
one who created this whole debate about the fencing technique versus the linear threading technique.
Yes. So I do not do the fencing technique in the entire lip. I only restrict it to the outer corners if I want to flip the lip a little, typically in older people. But I
Mm.
like his technique where he goes, what he does is in this, I also do that, is in the medial portion when you want to, create a nice, like uh, volumized, nice lips, what you do is you go from the median tubercle and you give a curve, you curve your needle in here, and then you start putting product all along the curve. So you
Mhm.
put the product here. So let me just see if I can. It's so difficult to show on yourself, but so you take the needle from here, okay, and keep going medially and curve it down, and then put your product like a hockey stick,
Exactly.
you
It's
know.
like you are drawing the filler product through your
Yes,
needle.
yes. So
Because
that's
a lot of clinicians out there do place the filler product regardless of the technique, and they depend on the molding to reshape it after they finish their injection. And I
but
don't think this is a right way to do it.
no, I think you should place most of your product in the right place and then mold it. That makes it, because and sometimes the lips are asymmetrical, so you want to correct that asymmetry. So every lip is not the same, so you can't, of course you can't do this curving technique everywhere. This is when you want to give a nice, volumization. And when you want to do the borders, you just do a little below the border. That's my technique again, because otherwise I see that it
Mhm.
does sometimes, give that ledge, you know which I do not
Mhm.
like.
Do you
I can't see. You have disappeared. There
Okay,
you
I'm
are.
sorry, I just lost you. Okay. Do you recommend injecting Botox across the vermilion border in a microdroplet pattern just to relax the orbicularis? oris muscle and to do
So,
this Botox lip flip?
so in my older patients, especially when I ask them to purse their lips, and I see that there are a lot of perioral lines as well.
Mm-hmm.
And if they have very very strong DAOs also, then I do like to do a little bit of neurotoxin as well. So, but I underdose it. I would just give, at the lateralmost corner of the orbicularis oculi, oris muscle, I would just give, maybe 2 units, 1 and 1.
Mm-hmm.
So that's my way of just flipping the lip. I don't like to do too much because, initially there's a lot of discomfort in the patient, because when the patient is trying to brush, or the patient is trying to talk or say a few words like oh, or it's a little difficult. So I don't like to
I
do the
never give more
entire
than
area.
1 unit. Yeah,
Yeah.
yeah,
So
yeah.
exactly. So I also actually do half and half, or really in a person who has a lot of lines, I would go up to 2, but not more than that.
Mm-hmm.
Similarly, if the DAOs are very strong and the marionette lines are very strong, then I would do
Mm-hmm.
probably 2 and 2 units in the DAO as well, to upturn the corner of the lip. So that also is something that I do. Um, I don't do the mentalis so much now. So if you see in my case, my mentalis is very active, right? But when I'm talking, you can't see my mentalis so much.
You look gorgeous, Dr. Jaishree, regardless of what you do.
Thank you, but I'm just that's so sweet of you. But I'm
Actually,
trying.
there's a funny question from one of our there's a funny question from one of our audience. She's asking you what lipstick you are wearing, ma'am. It's just
Oh,
she have gone throughout the whole concept of the webinar and she was focusing with your lipstick.
so I'm wearing a
Okay.
Kat Von D. I don't know the shade. I can see
Mhm.
after this. Maybe I can, message you. It's a Kat Von D, the brand. I love the brand, by the way.
Okay.
Okay.
Me too. And you look
So
amazing with it, part.
thank you, thank you.
So,
So what I was
so
trying to tell
Dr.
you
Joshi,
is.
tell. Mm.
So what I
Yeah,
was
sure,
trying to tell you.
continue. I should.
Yeah. So what I was trying to tell you is that, if you actually do a soft tissue augmentation, if you do fillers in this chin area and in the labiomental crease, you can give support to your lower lip, and there is myomodulation. So there is not much activity here, and there is a nice outward, when you pout, the pout is really natural and nice, because you
Mhm,
are doing myomodulation when you inject filler in the chin and in the labiomental crease, and that's exactly what I've done, which is why when
mhm.
you do this, you can still see my mentalis, but when I'm talking, it's not so very prominent, because the filler is doing its
Exactly.
activity.
Yeah. And I guess else we can do a non-surgical lip lift using fillers as a myomodulation by placing it deep to the elevator muscles of the upper lip
Yes,
and
yes.
superficial to the depressors. It will also
Depressed.
like beautify it indirectly. Yeah, yeah.
Yes.
Doctor,
It
we
also
have a
brings down
question.
the
Oh,
it also brings down the gummy smile. So if you just inject, filler in the in the nasal spine here, you'll see that a lot of times you have the depressor nasi action is taken care of, and the LLSANs also, and you have that myomodulation, and you don't need to give botulinum toxin for the gummy smile.
mm.
Have you seen that too, Doc?
Yeah, do you recommend using a high G prime in this area? I sometimes feel soft
Yes.
fillers don't give you this effect.
They don't. This no, no, no. When you're injecting the piriform, or the columella, the nasal spine, it has to be a high G prime. It has to
Exactly.
be. Yes,
Mhm.
yes, absolutely.
Sometimes when I fear of having a positive aspiration, I poke the skin with my pilot needle and enter with a cannula. I guess it will be a little bit more safe.
Yes,
So we have a question from some of our audience. He's asking you, is it safe to inject the philtrum intradermally instead of subdermal?
yes, of course. So I use the Bellatero again, the Bellatero balance, because
Mhm,
again, it's a very soft thing, and I pinch the skin. So I first draw my lines. I know exactly where I have to draw the filtral columns, pinch the skin, and actually go intradermal, and then put a thin drop, because you don't want to create too big ridges. That looks very artificial. So really 2 lines intradermally where you pinch and you inject so that the filler doesn't get swayed into the rest of the, the cutaneous lip. So it's very safe.
Okay. We have another question. Hello. If you could tell us more about upper lip lightening creams.
All right. Upper lip lightening creams. I again use a combination of vitamin C and and kojic acid, and I do a lot of times I do the lactic acid peels. So 20 to 30% lactic acid is what I do, and yeah, most of the time it's vitamin C with kojic acid that I give my patients. I don't use hydroquinone. I'm not a big believer of hydroquinone. I find it easier when people use a combination of CE, also a combination of CE ferulic acid, which is, I think SkinCeuticals has a very nice serum. It's the CE ferulic that really works well for upper lips, or for lip lightening. Sorry. And tell your patients not to use dark lipsticks, dark shades, dark reds, dark browns, dark maroons. There may be a little more lead content in the dark shades. Again, longer lasting lipsticks can cause a lot of hyperpigmentation. So that you've got to be careful. You must tell your patients not to purse or lick or smack their lips. This that also will cause chapping and then hyperpigmentation. I don't know if how the sweets are in Egypt, but in India, some of the Indian sweets, we have a silver coating, and there have been reports of Algeria where there's an allergy to the silver, and that also causes hyperpigmentation on the lips. Teeth whitening toothpastes have also shown to cause hyperpigmentation. So you have to tell your patients to avoid all these, and then you use these lip lightening creams. And I have to tell you that these very soft, like the Bellatero Hydro or these skin booster injections, many times, without doing the fillers, you just do skin booster injections. I've seen that hyperpigmentation reduces when you give these booster injections in the lip. It probably has to do with hydration. And in really, cases of lichen planus pigmentosis of the lip or Peutz-Jeghers syndrome, I do use a Q-switch Nd:YAG laser, and I use low fluence, and I do it once in about 6 weeks, probably in 6 to 8 sessions. The dark lips really, the hyperpigmentation literally goes off, reduces by almost 80%, sometimes even up to 100%.
Dr. Jaishree, given the fact that you are one of the top dermatologists in India, I guess you are very familiar with the growing trends of the Russian lips and patients who want to have a 50-50 lips. Are we starting to lose our visual perception of what is normal? People are always taking a fake look, and this is taking the industry to a dark side, if you know what I mean. How can you educate your patients about what is normal, what should their expectations should be, what does fit their face and but what doesn't? And I have seen your lip masterclass. You always do those natural, smoothly looking lips. So what is your opinion about this?
So it's a very sad situation. Back in the day, people would come and say, "I want lips like Angelina Jolie." Then that changed, and then people said, "I want lips like Kylie Jenner or Kendall Jenner." And now people come and say, "We want the Russian lips," right? But every time they are trying to ape somebody else, right? And it's our duty as physicians, as clinicians, to tell them that, every lip has its own unique property. We cannot make your lips look like somebody else's lips, because those lips may not look good on your face, because your facial structure is different, your facial shape is different, the way it blends with your eyes, nose, and chin is going to be different. So you can make your thin lips plumper, you can define your lips, but making it look, like somebody else is not really a great idea, because at the end of the day, to keep it natural, is what makes it look more beautiful. You don't want to walk into a room with your lips walking in first. And a lot of people who actually see people walking in with the Russian lips, with due respect to everybody who loves the Russian lips, but a lot of people get scared. And when you tell them, maybe you could do a lip filler, they're like, no, 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 no. Because their concept is, because they've started looking at Russian lips and they feel that it looks terrible. So to one part, it's like every doctor is making, no, I think so people come and say, no, 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 you know what? Lips look horrendous. They look artificial. People can make out. People will say, people are more worried, in my country at least, about what they feel that, everything should be subtle and natural. That is majority of them. Say 80% of them will want a natural and normal, yet sexy and feminine and nice lips. Even men, want nice lips. But they have that fear that what if my lips start looking artificial, like those 20% who love the Russian lips or the artificial lips or the big lips. So I think,
yes,
it's our duty to educate people and tell them that, okay, some people, I have to admit, carry the Russian lips very well. They look good, but not everybody can carry it well. I think 90% will not be able to carry it well. And the way you inject the lips has to be in proportion to your face and the shape of your face and your ethnicity. So
I guess the problem is that actually I guess it depends on the doctors. The problem is most of the clinicians who are very fond of those techniques are advertising for it. So
yes.
The patients are still poor at the end. They need to be educated. How can you educate the people if you are advertising for bad practices?
Yes.
It's not normal to have an eyebrow that is lifted like this.
I wanted to ask you about that. Yes. So I wanted to ask you, because I did see your fox eyes. That trend has still not come to India. So I was a little.
And I hope it stay like this. It should not be allowed to enter to India. It's going to make people look like aliens. I don't understand. Look, it's normal to lift the eyebrows if you have a little bit of a hooding, or you want to lift it in a little natural way. But why would you like to have like a fox eye by having a thread from here up to your temple? God didn't create us this way. I mean, it's look catastrophic.
Absolutely. I think we should, somehow educate our patients. And also, I'll tell you what, Dr. Noury, these are all passing fads. They keep changing. These trends will keep changing. So today, yes, they like the technique. They love the big lips, equal proportion, huge, flipped out, those typical, whatever we call the Russian lips. But tomorrow it's going to die. The same people will come and say, dissolve it for me. I'm telling you. Something else will come up.
Yeah.
So I think we
giving the fact that those things may give a high risk of complications. Did you see any cases of having such practices and came to suffering from occlusion or from a weird look, and they are just asking you to dissolve this filler?
Yes, I've had 3 cases so far where people have come. Some of our patients do go to to UAE, and there are a lot of doctors from Russia who come to the UAE and they inject. And I've had 3 patients who've gotten injected and come back, in the next day or something, and then it's usually the 3rd day that suddenly, from what they consider a bruise, it's actually spread to the nose. And I've had to flush the entire thing with hyaluronidase, because it's not basically the filler which has gone and punctured a vessel. It's actually the pressure of that amount of filler, which is sort of creating a vascular complication, almost heading towards a necrosis. So too much of product, the lip is only that much. You can't fill in that much product, right?
Yes, and the muscle will always try to compensate to push this product out of it.
Yes. And because of that, and the superior labial artery can only do that much. And then, there is a direct connection. So I've had 3 cases. And I've also had a few cases of polymethyl methacrylate, which was injected in the past. And again, a lot of it injected, which, I've had to dissolve because there was sterile pus in it. There was suddenly, like, the patient developed some infection. And then when you give antibiotics, it doesn't go. It's, it's on and on and on. And then when you actually, see what it is, it's actually an old filler, and then they give you the history of polymethyl methacrylate. So I'm very scared of injecting too much product in the lip, and I'm very scared of injecting anything but hyaluronic acid. So these are the 2 things, which is why I don't think, with due respect to all my colleagues who do Russian lips, I don't think I will be able to bring myself to do it, because I don't want to. So what are the danger zones? The glabella, the nose, and the lip, right? These are the 3 most, the most common danger zones which can lead to blindness. And that's the last thing that my career would be finished.
No, this would never happen, Dr. Jaishree.
No, it won't. But what I'm trying to say is that is why risk it? Why risk
exactly.
it? It's not worth it. It's not worth
it.
You
should always be smart, regardless of how much you have been practicing this specialty. Yes, exactly. So I'm going to take 3 questions from our audience. Then anyone who have any more questions, spam Dr. Jaishree inbox, because we took too much time, and I'm sure that you're starting to get tired. So we have a question.
I'm happy to be with
the pleasure's all mine.
The good thing is, for us, it's a Saturday night. So,
yes,
I can sit with you, no problem.
Okay. So we have a question here: how to ensure the depth of the soothe without being superficial to the muscle and not deep to the bone?
But why would you want to be, not want to be on the bone? So my thing is, when you want to inject, of course, when you inject, you feel a giveaway. And when you feel a giveaway, and that's the time that you've gone through the soothe, But why? My question is, why do you want to
you can touch bone and slightly retract it a little bit and do the injection.
Yes. So number 1 is that you must put a little product on the bone. Okay? And then withdraw your needle and maybe put a little, you have that giveaway, you put a product, and that's it. A little bit of it is going to come to the soothe. The area is so small. Don't you agree with me, Doctor?
Yes. And you said something that is very, very magnificent. I don't know if our audience considered it, but you said you place a micro aliquot. So it's like this area is very tiny and compressed. You don't want to over compress it with your filler product. You just go smoothly with your needle or cannula and place a micro aliquot product. Yes.
Because you don't want,
we have another question.
Later on, you don't want some swelling under the eye. After I have seen patients come after, Dr. Noury, I've had a patient who had bulges under the eye, and she never told me what was the issue. And I would always say, I think it's a filler, let me dissolve it. And she would refuse, and she'd say, I'd never had filler. And and then when I once was with Dr. Becky Fitzgerald in LA, she dissolved a filler which was about 4 or 5 years old. And so I came back, I told this patient that, listen, I think you've forgotten. Let me put hyaluronidase and see. And then she said, no, doc, you know what? I have done Restylane 8 years ago. I said, never mind. And I have actually been able to dissolve the Restylane after 8 years. So sometimes the filler will migrate. Sometimes a part of it stays. It absorbs so much water. It puffs up. The under eye and the lip are areas where you would want to underdo, and especially the under eye area, the entire infraorbital hollow. Please underdo, never overdo.
Yes, and it have also a high surface volume coefficient, so filler
Absolutely.
product will always tend to disperse regardless of your
Disperse.
technique. So yes, exactly. Uh, we have another question. Is it safe to inject the body of the upper and lower lip in the midline as the superior artery may run superficial at this site? This question from Ahmed Nadal. Okay.
Sorry, what, can you just,
Yeah,
is it safe to, yeah,
yeah.
I can read that question. Inject body of the upper and lower lip in the midline.
A superior artery may run superficial at this site. Yeah.
No, so I'll tell you, the artery doesn't become superficial. It just gives out branches, right? So it's absolutely okay to inject in the midline. Now, this is a very this is interesting. Actually, we didn't discuss the vessel. So it's always taught to us. It was taught to us that, So where does the, so you have, from, if you clench your teeth and you palpate your masseter, and at the anterior border of the masseter, the facial artery becomes superficial. And then it starts to come out like this. And about approximately 1.5 to 2 centimeters away, it gives out a superior labial and an inferior labial artery. Now, we were always taught that 80 to 90% of the times, these two arteries are running below the muscle, right? So it's very, very safe to inject above the muscle. So don't go deep. There was a recent paper published by Sebastian Cotofona where he said there are only 56% cases where it is above the muscle, okay, between the skin and the muscle. 36% of the times it is intramuscular. And 5% of the times it can be below the muscle.
So it's always safe to stay superficial.
It's very safe to say superficial, number one. Number two, these days, Dr. Noury, I've started using the cannula. And I love it.
Do you do a single puncture for both upper and lower lip? Or you
No,
do two punctures?
I do punctures. I tried doing the single, but somehow if I want to give that Cupid's bow and a nice shape,
Yeah,
I
it will be
prefer
hard.
doing it. Yeah, I like to do it from both the sides. And,
Yeah.
but of course, the same puncture obviously for the upper and lower. So, so that's what it is. But you could still be superficial and still hit the vessel in those 5% cases. So it's a chance you have to take when you are injecting. As Dr. Arthur Swift says, when you're injecting, don't look at your syringe. Don't look at the volume that you're injecting. Look at where you are injecting. Because if you see blanching or if you see a color change, then you know that something is wrong. So that's very important, even when you're injecting the tear trough. So if you see a lot of times the vascular complication, the patient will come to you the next day and tell you, right? The
But you
bruise
always
has
have an
gone
early signs that give you a little hint that is something is going
Yes.
to happen.
So we as clinicians should look at that and see, is there a little blanching? Is the pain a little more than what it should be? Sometimes, you will immediately in half an hour see a purplish, like a livido, a purplish discoloration. So these are signs which you have to pick and say, okay, I have to use hyaluronidase and flush the area.
I wasn't intending to ask this question, but since you came up with it, and I'm trying to take advantage of your huge experience, given the fact that hyaluronidase do break down the native hyaluronic acid that we have in our body, how much do you use saline for the reconstitution?
Oh, so I use 5 cc of saline.
Okay. This
I
is for
add
vascular occlusion or for dissolving lumps and bumps?
for dissolving.
Okay. Okay.
For vascular, I think so. I've only had a vascular compromise in my patient once, and that was again the lip. That was, I started injecting the lip in 2004, And my one and only complication, vascular complication in the lip, happened in 2017, after 13 years. And that taught me a lesson that, it can happen to anybody, anytime. So you have to be more vigilant. And if you see that blanching, I remember very clearly, I saw that something is not right. And I still said, it's okay. And so when your gut says that something is not right, you have to listen to your gut and your intuition. So,
I know this feeling of this. It's going to be fine once he eats and drinks and he talks. Everything's going to be fine later on.
Yes, absolutely. So in that situation, I did, just use a 2 cc dilution and I flushed the area. But otherwise, usually I use a 5 cc. And even that I hyper dilute after. So I use, I only take a 0.4 from the reconstituted hyaluronidase. I take a 0.4 mil, and then I add a 4.6 mil of normals I don't use saline, I use xylocaine, and that's how I dilute it. Hyaluronidase can be, one, it can be painful. Two, we don't have vitreous here. So I see a lot of reactions. A lot of people are hypersensitive to hyaluronidase. I am hypersensitive to hyaluronidase. My lips will go like that, like something like a, not even a duck, like a bill or something, if I take hyaluronidase. So you've got to be very careful with hyaluronidase.
So what is the alternative in this case?
I think the vitreous is safer. I don't know if you have it in your country.
No, we just have Hyalase, which is 1,500 units.
Yes, so that's what we also have. So the best is to dilute it in a 5 cc dilution. And, if I have to dissolve the lip, I am very, very careful. I don't give more than, once I've diluted it, I take it in an insulin syringe and I do just about 5 units, 5 to 10 units, not more. I wait. I like to wait and do it rather than just flushing a lot, because as you said, although a lot of my colleagues and teachers, we all believe, and papers have also said that maybe, it doesn't do anything to the normal hyaluronic acid, or maybe even if it does something, it rejuvenates, the normal HA rejuvenates. But I still like to be careful, and therefore I do not overdo the hyaluronidase. So I may call my patient a second time, after maybe 3-4 days and look at it and say, if the patient needs a little more dissolving, I do that. But by God's grace, I haven't had to do that in my own patients. The dissolving only happens when they come from elsewhere. Another thing about hyaluronidase, I'll tell you, if you use the Y-cross technology, which is the Juvederm, the Ultra Plus Voluma, it's the Y-cross technology. It's very difficult to dissolve at one go. I don't know if you've seen that. You have to.
Actually, you know what? It also depends on the technique of delivery. Linear threading are easier to get dissolved more than bolus, and also it depends on the G prime. Yeah. So I guess you should start from the very, very beginning to take care of your anatomy, take care of the type of product you are using, and the technique of delivery of this product. So when things go dark, you can reverse it.
Everything works. Yes, it is something that works like synergistically, and it can't just be your technique or just the anatomy or just the product. It has to be all. And also the entire, if we're talking of lip, you just can't just do the lip. You have to look at the perioral area. Similarly, if you're looking at the tear trough, you can't just do the tear trough. You have to look at the mid face. You have to look at the temple. So, it's always a more holistic approach that works better.
Okay, this is very, very good. People are asking me to save this webinar. This one is the best one yet. So, okay. Dr. Jaishree, we have been rated the best webinar among my all guests that I have interviewed.
Thank you so much. That is so sweet. Thank you.
Yes. The pleasure is all mine. Thank you so much for your time, Dr. Jaishree, and for
Thank you.
accepting me to join me in this webinar. It's been a great pleasure and privilege. And
Thank
did
you.
you ever come to Egypt?
No, in fact, I was going to come in October for the Sharm and we were
Uh-huh.
going to have an ISDS meeting. So I was coming to Cairo because Sahar had invited me, and I'm also the board of directors of the ISDS, so it was going to happen. But unfortunately, because of this, the meeting got cancelled. So do you know Sahar Ghanam? She's a very good friend of mine.
Yes, yeah. The whole Shard Derma team, they are
Yes,
doing a lot of. They are doing this beautiful conference here.
yes,
I guess we will be truly honored and privileged to have you as a speaker in a conference or a course here in Egypt. I just have
next,
one
yes,
last
I would love
question.
to come. I would love to come next year, maybe.
Yes, the pleasure is all mine. And I'm going to take a selfie with the best celebrity cosmetic dermatologist. Okay. So when you come, I must be known. So,
We can take
Dr.
a picture
Jaishree,
now.
yes, I'm going to take a selfie and I'm going to send you tomorrow, hopefully. I want to ask you about something, lastly. Since the fact that I'm an oral maxillofacial surgeon from a dental background, I guess you know that there is a lot of aesthetic nurses who are practicing facial aesthetics. Do you think dentists who want to practice facial aesthetics should be practicing it? Or what is your own opinion about this? Because here in Egypt, we do have this quarrel between dermatologists, plastic surgeons, and dentists who want to practice facial aesthetics. We don't have any aesthetic nurses here in Egypt, as far as I know. Uh, so, what is your opinion about this?
So I'm not in favor of nurses injecting, but plastic surgeons definitely, of course, it's their right. Dermatologists, yes. And I think maxillofacial surgeons, you understand the anatomy, and a lot has to do, as I said, the dental, you have to look at, at the dental arcade, the gummy smile, a lot has to do with the masseters, the TM joint. So why not? I don't think there should be a problem. um, I don't see why, because you're doctors at the end of the day.
Yes, but also you have to take a full training program and to be very qualified and to have a degree that allows you
So
to
I
practice
think
so things.
I think
It's not
that
something that
I
you can
think
learn from a
so.
YouTube video. Yes.
No, so Dr. Nouri, I would like to mention that that holds true for anyone who is an injector, even a dermatologist or a plastic surgeon. We are not
Mhm.
taught, injections in our curriculum,
Exactly.
right? So anybody who is going to be an injector has to have a proper training, and it's not so easy. You have to have a thorough knowledge of anatomy, and you have to have an aesthetic eye. You can't learn some
Mhm.
codes and inject some places and make every face look the same. You have to have that artistic eye of a sculptor to be able to enhance the beauty in that individual. I think that's my
Mhm.
belief.
So it all depends on gaining knowledge and studying tons of research and tons of works and to be fully trained to take cadaver dissection courses in order to be qualified to do
Yes.
this. Yes.
Yes, absolutely. I am still learning. I still learn
Mhm.
every day. I'm still, I have so I don't know how many webinars I have attended on the same tear trough or the lip, or in spite of conducting webinars I have attended also. I still love to go and spend some days with my colleagues in the US and Europe, and you know uh, you always have few take home points, and then you feel, oh, maybe I could add this, I could incorporate this into my technique, and that will help, you know. So it's always a learning process, and you have to
Yes,
evolve, and you have to.
mhm. And this is one of the advantage of COVID, that it gave us this break, so we can have a lot of
Yes,
free educational webinars the whole
yeah,
day.
of course. Yes, yes, we have to
Thank
look
you
at the
so
positive side. Yes,
Yes, thank you so much, Dr. Jaishree.
I
I hope
thank you.
you can come in Egypt at a very time soon. Thank you so much for your time. I'm truly privileged and honored. And I hope that
Thank
you had
you.
fun as much as I did.
I
And I
did,
hope I
Dr.
can see
Noury.
you in real life one day. Thank you so much,
So
doctor.
hopefully, yes, thank you. And a big, big thank you to all of you who have, watched this live, who have joined us, because you people make it more interesting. Otherwise, just two people talking doesn't become so. Thank you for joining us. And thank you, Dr. Noury, once again for your faith and trust in me and for inviting me and for giving me this honor. Thank you.
The pleasure is all mine. Keep amusing people with your beautiful titles, your beautiful work. And I totally respect your experience and your long journey, Dr. Jaypee. Thank you so much.
Thank you.
Good night.
Thank you.
Bye bye.
Bye. Good night.
Bye bye.
Bye.
Bye.